Hello, everyone. My name is Dr. Joseph Frenkel, and I'm a colorectal surgeon. I work for Secours Health Systems. My offices are in Harborview, and I mainly do my surgeries at Maryview Medical Center. As you all know, this month is Colorectal Cancer Awareness Month. And so the first thing to discuss and make sure everyone knows is that colorectal cancer is a preventable and treatable disease. And so everyone that needs a colonoscopy should be discussing that with their primary care doctor to be sure they're referred for screening colonoscopies. And my work is mainly in colorectal surgery. I trained in Boston at Boston University Medical Center, did 2 colorectal fellowships. One fellowship was for all colorectal surgery, and a second fellowship was for minimally invasive techniques. I do lots of different types of surgeries, not just for colorectal cancer, but also cancer, anorectal conditions, such as hemorrhoids and fissures. But my main interest is colon and rectal surgery. And fortunately, if we find colon cancer early enough, we're able to treat it with surgery with low rates of recurrence. And that depends on how advanced the disease is at the time of diagnosis. If the disease is not spread yet, it is potentially curable. Sometimes after surgery, chemotherapy helps in preventing recurrence. Secours has invested a lot in trying to assist surgeons in the most minimally invasive techniques possible to surgically treat colon cancer after it's identified. For me, this includes laparoscopic colon surgery, single incision laparoscopic colorectal surgery, and robotic surgery. In particular, robotic surgery is something that's been performed at Maryview Medical Center over the last several years. And the institution has just invested in the most up-to-date robotic surgery platform currently available. We've had wonderful success with our patients, minimizing pain after surgery, reducing hospital stay, while maintaining high quality results from the surgical procedures we perform. We have a dedicated operating room staff which performs the majority of these surgeries with us, and this has made this a very streamlined, successful program at Maryview Medical Center. In addition to performing these sorts of surgeries, we do a lot of garden variety surgeries. Used to be taken care of by proctologists. Now we are known as colorectal surgeons. And this includes things like hemorrhoids, fissures, abscesses, anything in the anorectal region that cause symptoms. And these procedures are also performed on a regular basis.
Who needs to be screened with a colonoscopy? You mentioned that earlier.
Yeah. So the general screening guidelines are age 50 for most people, although some guidelines are now asking African Americans to start their screening at age 45. Now, that's a general guideline. You should, of course, talk with your primary care doctor about it. Some people are initiating their screening a little bit earlier, in particular patients who have a family history of colon and rectal cancer. And additionally, if you have specific symptoms, those are the kinds of people that may require colonoscopy sooner than their regular screening timeline. For example, we very often see patients in our office with rectal bleeding. People have a bowel movement and see some blood on the toilet paper or in the toilet bowl. And that person, depending on their age, would also be someone who would want to have a colonoscopy just to be sure that there are no issues upstream from garden variety problems like hemorrhoids causing their bleeding.
What does minimally invasive surgery entail?
So minimally invasive surgery began in colon and rectal surgery around the turn of the century. And just like minimally invasive surgery for gallbladder surgery, we use very small incisions to do colon surgery. Colon surgery used to require a very large incision in the middle of the abdomen to take out the cancer. And now we use a series of small incisions, usually the size of a pinky or a thumb, to do the procedure. The procedure still does require a larger incision of about 3 to 4 centimeters to remove the actual colon with the tumor. But in general, the size of these incisions are much smaller than they used to be. And as I said before, that leads to decreased hospitalization length, decreased pain, and further return to full function. And that's something that carried over from laparoscopic surgery now into robotic surgery. And what we're finding with the robotic procedures that we perform is that although incision sizes may be similar, patients seem to have a lot less pain, and hospitalization may be even a little shorter after the robotic procedures.
How do the robotic procedures work?
So the robot is not a lifelike looking robot with arms, legs, and a head. It actually is a device that is brought in to the patient at the bedside during the surgery with the arms that hold instruments. We sit at a separate console, and at that separate console, we use essentially what are joysticks and a very accurate three-dimensional viewing instrument to be able to move the instruments. And one of the major benefits of using the robot is that the ends of the instruments can actually rotate in a 360 degree range and can bend in all directions, just like your wrist. It's termed endo-wrist motion. And that gives us increasing ability to be as precise as possible with our surgery. So we should think about robotic surgery as not another person or a robot performing the procedure, but it's yet another tool in our armamentarium that we use to perform the procedures. Of course, we're in full control of the device and quite accurate and precise control at that.
Can you explain what colorectal cancer is?
So colorectal cancer is a mutation in the lining of your colon, and we normally have polyps that can develop over time. That's not that uncommon. Maybe 20 to 30% of the time when we perform colonoscopies, we find small polyps. These polyps can be removed colonoscopically, and when they're removed, we're preventing the progression of those polyps into cancer. The cells in the polyps can further mutate, and these can grow into cancers. And they're defined as cancers once the polyp, which begins to develop these cancerous cells, invades through into the deeper layers of the wall of the colon. And that's when we have a cancer by definition. The cancer can further spread to the rest of the body, making it a more severe form of the disease. And of course, the goal is to find these polyps or cancers as early as possible, to remove them surgically, and to prevent the progression of the disease.
A specific question here, are the outcomes of robotic surgery better than laparoscopic?
That is a very highly debated topic. I can tell you that's still under very heavy investigation, and we don't have any real answer for that from a research standpoint. From a surgeon's perspective, I can tell you that the surgeries done with the robot are quite accurate, quite a bit easier in some circumstances for us to perform, given the robotic abilities, given the ability to bend the tips of the instruments back and forth, and in particular to work in tight spaces. For example, rectal cancer in particular is a disease that involves the lower pelvis of the abdominal cavity. That's a relatively tight space. And so when we perform robotic surgery in that location, not having our cells fighting with each other to try to get all of these instruments into such a narrow cavity, but the robot instead offers a substantial benefit. And that really is one of the areas where robotic techniques really has become something that many surgeons in our field find to be the most applicable.
What are some risk factors for colorectal cancer?
Well, unfortunately, most of the time colon cancers develop spontaneously. The mutations that we discussed earlier are almost always spontaneous, at least 80 to 90% of the time. The remainder of the cases can be genetic, and We're doing a lot of research into the genes that are related to colon cancer, and very often we will test patients who develop colon cancer for those genes so that we can counsel family members as to whether or not they should have more aggressive screening protocols. Beyond that, there have been some environmental factors linked to colon and rectal cancer, such as red meat in particular made some headlines in the news, obesity, smoking and alcohol use can contribute. But a lot of these environmental factors are very difficult to study in isolation, so we really can't say for sure. But the vast majority of time, the cancer is developed spontaneously. And so that's why we strongly urge patients to have screenings to find polyps before they develop into cancer to prevent it.
More questions online. I had a colonoscopy at the age of 50 and was told I don't need another for 10 years. That seems like a long time. What is the recommended time frame between colonoscopies?
That's a very good question, and 10 years does sound like a long time. However, the common thought is that it takes 10 years to develop a colon cancer. And so if you have a colonoscopy and the colonoscopy is entirely normal and your bowel prep was not limited in any way, then 10 years is the standard guideline. And if you look those guidelines up, lots of different societies will recommend a 10-year follow-up for your next colonoscopy. Now that can change. Let's say the gastroenterologist or colorectal specialist found that you had a little bit of stool left over. They might recommend 5 instead of 10 years. Let's say we found a polyp or 2. That in particular dramatically changes things. If you find 1 or 2 polyps, many might recommend 5 years instead of 10. If we find several polyps or larger polyps, we'll actually recommend, for example, a 3-year. So a lot of it is a little on the subjective side and based on your study and the comfort level that the gastroenterologist or colorectal specialist had in performing your procedure. What would tell me is it's very likely that whoever performed your procedure thought that your bowel prep was excellent, you did a good job, good for you, it really helps, and that they were very comfortable and confident they didn't see any polyps. Is it possible between now and 10 years you'll develop new polyps? Absolutely. But we need to make these guidelines based on the progression of the disease, and we're treating the entire population of people, not just 1 in a million. So we need to make guidelines based on all of that. So 10 years is a very reasonable thing to say if all the above were true.
Any final thoughts?
No, I thank you for spending a few minutes with me talking about colorectal cancer and colorectal surgery. And once again, since it is Colorectal Cancer Awareness Month, please be sure that you've thought about whether or not you need a colonoscopy and discuss that with your primary care doctor if necessary. Have a good day.